Recording in progress. Recording in progress. Recording in progress.
Okay, so hello, good evening, everyone. I am Dr. Shantanu Dubey, and I am a consultant orthodontist. I did my BDS from ITS Dental College, Muradnagar, and then my MDS from Sukati Dental College, Meerut. Okay, and then I worked as assistant professor in IP Dental College. Further on, I went to a private clinical chain as a consultant orthodontist, of course. But then my love was always for academics. So right now, we are here to discuss a few questions that have been there in the NEET NDS exam, and those are really important. And I feel that once we discuss this, we would be able to understand better how to approach the orthodontic preparation for your NEET MDS. So, what I feel, which is true for every subject that is there in the MDS exam, I would say that sticking to basics and understanding the concepts is the most important thing that you can do for your preparation. And that starts from the year that you are studying in itself. So, moving on. So, the first question that we are tackling here is the very basic, and this concept you'll encounter in the very beginning of your orthodontic studying, which is that the question is, well, heavy orthodontic forces, well, continuous heavy orthodontic forces cause. The options that we have is hyalinization of PDL, resorption of cementum only, resorption of alveolar bone only, and rapid tooth movement. So you can uh, either directly approach the question and directly understand the option and tick, or what you can do is move with the concept of elimination. Both of them are okay. So the first things that we see is that will it cause rapid tooth movement or not? We as a dental student understand that just by increasing the force, you cannot increase the speed of the tooth movement, right? If that was true, why would an orthodontic treatment go on for 1 year or 1.5 year, right? So uh, it would just finish in a month if we wanted, right? But that's not true. So it won't cause rapid tooth movement. Resorption of the alveolar bone only, and resorption of the cementum only. So whenever there is only, the answer has to be like very, very accurate. So the question that comes to our mind is that whenever we are applying heavy orthodontic forces, will it just affect the alveolar bone or just affect the cementum? We understand that if heavy forces are applied, it can cause mobility. So it is affecting the alveolar bone for sure. But does it not affect the cementum at all? Do we not know about the root resorption, which may be caused by the heavy orthodontic forces? We already know. So the three options are eliminated. But then, of course, if you have studied well, you would already know the answer, which is the hyalinization of the PDA. So let's understand some basic concept behind it. The concept is very easy. So whenever a force is being applied, there is a pressure side and there is a tension side, right? So we already know that on the tension side, there is formation of osteoblast, and on the pressure side, there would be formation of osteoclast. So of course, the osteoclast, as the name suggests, would resorb the bone, and the osteoblast would deposit the bone. So while we tackle the heavy orthodontic forces question, we should understand the basic of the tooth movement. So whenever we apply any force, this thing happens. And the movement is divided into three phases. The first phase is initial phase, then the lag phase, and the post-lag phase. So the initial phase is when there is slight displacement of the tooth inside the socket itself, because there is compression of the PDL fibers, right? There are PDL fibers all around the tooth, between the bone and the tooth. And whenever we apply some force, this gets compressed and there is little bit of tooth movement. So of course, you'll see it right then. So the initial this kind of movement or the initial phase is seen within 24 to 48 hours. This is 1 hour, 1 day, or 2 days. For the lag phase, there is minimal or no movement. Well, the name itself suggests lag. There is lagging in the movement. So if you break down, there is minimal or no movement. The question is, why is there no movement? Well, the answer is pretty simple. We understand that PDL also contains the blood supply. Now imagine you have put so much pressure that the entire PDL gets destroyed. It gets totally compressed. So the blood vessels inside also get compressed. And if there is no blood, there is no oxygen. Of course, there is cell death. So cell death due to ischemia. And this cell death is represented by hyalinization. Hyalinization is simply hyaline means glass-like. So the nucleus fades away, which is the first sign that the cell are dead, and the cytoplasm becomes glass-like. So there is local necrosis of the PDL cell on the pressure side. And hence, since hyalinization would impede the bone resorption process, well, of course, if there is no blood vessels, there is no way for the osteoclast to come, because we understand that osteoclast is nothing but a modified giant cell. So the giant cell comes from the blood vessel. Blood vessel is already compressed. Blood vessel is already compressed. I'm sorry. So the blood vessel is already compressed. There is no way for the osteoclast to come, and hence there is no bone resorption. And hence since there is no bone resorption, the tooth cannot move, and hence there is a lag phase. And finally, the post-lag phase, where the bone remodeling resumes. So whenever there is bone resorption from the front end, this is frontal resorption. And whenever there is hyalinization, the osteoclast cannot come from the PDL side, they come from the bone side, and hence, which is called undermining resorption, which takes some time. And hence, there is a gap of 7 to 14 days. So after initial phase, there is a lag phase of 7 to 14 days for the hyaline layer to move out using the undermining resorption, and that's what causes the lag. Post lag phase, the bone remodeling resumes, and there is tooth movement. So there's no doubt about that. Okay. So say this graph, you must be able to identify this is the initial tooth movement. Whenever the force is applied, there is 1 mm around, less than 1 mm of tooth movement, which is inside the PDL space. And then there is lag phase. As you can see, there is no tooth movement. And again, there is a slope upward, which says there is tooth movement, which is after the log phase, which is lag phase, which is the post lag phase. So another 2 or 3 things to know is that what is hyalinization? It is a type of coagulative necrosis. So this leads to delayed or undermining resorption, and controlled and light forces. If you apply, you can avoid this hyalinization. Hence, there is better tooth movement. That is why it is said never to apply huge amount of force during tooth movement. So this is all. Sometimes they ask you image-based questions. So I just wanted to show you once. This is the tooth structure that you can appreciate. There is the bone. In between, there is the PDL. And here you can see this glass-like structure, which is the hyalinization. Hyalinization. And that's what impedes the tooth movements toward the pressure side. Okay. So see, the optimum force is between 20 to 26 gram per centimeter square of root surface, which is basically the intravascular pressure of the capillary which is present. So that is why this much amount of force is applied, so that it doesn't compress the blood supply and hence cause hyalinization. Okay, so the second question, which is a case-based question and which was asked in NEET, I think in 2022. So the question is very, very simple. If you understand, we'll move through the question slowly. So 2 girls of 11 years come to an orthodontist, and the first one has attained the menarche. So the patient has started menstruating, right? While the second one with short stature has not. Both of them are 11 years, but one has achieved these menarche and the second one has not achieved the menarche. The hint that they are giving is that the stature of the patient is short. So the question is, which one of them is ideal candidate for a functional appliance therapy? So the patient needs functional appliance. We just have to decide which one would be a better candidate. So the first option says first one because the patient is early maturer, has attained peak height velocity. The second option says first one because late mature and has peak height velocity. Okay. And the third is second one because she's early mature and yet to attain peak height velocity. And fourth and final, which is the correct one, which is the second one because late mature and yet to attain peak height velocity. Okay, let's tackle it one by one. But before we do that, we should understand that functional appliance, as we understand, would act better when the growth spurt is yet to come. Peak height velocity gives you a hint about the growth spurt. The person who has already attained peak height velocity has passed the growth spurt, or this point of time is at the growth spurt if the person is at peak height velocity. But attained, so they have already passed the peak height velocity. So the first two options are out of the park because we don't want to give a myofunctional appliance to a person who has already passed the growth spurt. The third and the fourth question, the third and the fourth option, which the first one says, the third one says, second one because she's an early maturer. Well, the question is, if she is an early maturer, then why at 11 years of age, there was a girl who has matured, has attained the menarche, while the second one is still not attained the menarche? So we have this doubt: is she an early maturer? The second hint that they give is that the patient is short stature. Well, if she was an early maturer and she has a short stature, she has not. I mean, these three things don't fit together. So the best patient would be that she is a late maturer. So the growth spurt is yet to be achieved. We are yet to enter the growth spurt, and peak height velocity has also not been attained. We are yet to attain the peak height velocity. Now we can give a myofunctional appliance. The moment she achieves the peak height velocity, we will see a good amount of mandibular growth. So this patient automatically becomes the best patient for the myofunctional appliance. So the few of the concepts that you should know around this question is that what are these growth spurts? When do they come? So we can broadly classify them into infantile or early childhood growth spurt, which is the first growth spurt, which is seen 1 to 3 years of life. Juvenile mid-childhood growth spurt, which is often noted around 6 to 8 years. Pubertal, which is the growth spurt that we mostly use as an orthodontist, which is the pubertal growth spurt or adolescent growth spurt. So which is at the timing of the puberty. So for girls, it is so easy for us to identify whether the patient would be benefited by the myofunctional appliance or not. We simply ask the patient or the mother that whether the patient has achieved menarche or not. Once she has started menstruating, the chances of she getting advantage of a myofunctional appliance for the mandibular growth well reduces quite a lot. Okay, so always remember this concept. So the timing for the girls for the peak height velocity is 11 to 12 years. Of course, girls mature first. We all know that. And for boys, it is 13 to 14 years. Okay. So boys experience their peak height velocity approximately 2 years after the girls. So again, so this will help you in diagnosis. When the patient comes, a similar question can be asked. With the genders changed, I mean, a 11-year girl and an 11-year boy has come to you for a myofunctional appliance, which is the best patient for you. Of course, the boy is a better patient because he has yet to achieve the growth spurt for sure as compared to the girl. Okay. The second question is, well, I would say it is more towards, less connected to understanding the concept and more about the factual information. The question is, according to Simon classification, the movement of teeth towards the Frankfurt plane is called attraction, abstraction, protraction, retraction. Okay. So the answer is attraction, but you can utilize the understanding of the concept. I would tell you how. So we understand that Simon, what he did was that he utilized the anatomical planes in relative to the cranium to understand the malocclusion. Okay. So the three planes that he utilized was Frankfurt horizontal plane, orbital plane, and the mid-sagittal plane. Well, we all know from the first year itself, which is from Frankfurt horizontal plane, because we had to hold the skull in the anatomical position. So we knew about two planes. One was Reed's, one was Frankfurt horizontal plane. So we already know that it passes a plane which passes through the porion to the orbital. So you can see the first image on the right side. This is showing the Frankfurt horizontal plane, and the question is about Frankfurt horizontal plane. Uh, so the Simon used two terms for this: attraction and abstraction. For the orbital plane, you can see this is the plane, the image in the middle. So the vertical plane passing through the orbital, but is perpendicular to the Frankfurt horizontal plane. And the third one is mid-sagittal plane. We don't need to guess about this. This is the plane passing through the mid of the skull, dividing the space into two symmetrical halves. Okay, right and left. So that is your mid-sagittal plane. Now, to understand, let us ignore Frankfurt horizontal plane for now and focus on our orbital plane and mid-sagittal plane. Okay, so orbital plane, if you see passing through the orbital and perpendicular to the Frankfurt horizontal plane, we have to imagine whether the tooth is moving towards the plane or away from the plane. Now, if the tooth is moving towards the plane, don't we call this retraction of incisor? We are retracting the teeth. Or if you are not aware about this terminology, I'm sure you are aware that whenever the teeth are in forward direction, we call that proclined. So can't we remember that when the teeth are proclined, they are away from this orbital plane. So we can call this protraction. And when we take these teeth back, this would be called as retraction. Again, if you imagine the maxilla and we imagine the mid-sagittal plane, whenever the maxilla is moving, I mean the arches of the maxilla are moving towards this plane, this would call narrow maxilla or a contracted maxilla. And when we open up the maxillary suture, we expand the maxilla, we distract the maxilla. So we can always utilize this. And finally, otherwise you'll have to mug up, which is Frankfurt horizontal plane. He used the term attraction when they're moving up towards the Frankfurt horizontal plane, which would be in the case of open bite, the incisor are less erupted, they are moving towards Frankfurt horizontal plane, or abtraction when they are moved further away from it. So it would lead to deep bite if they are talking about the upper teeth. Okay. Now, this is a concept which you'll encounter right in the beginning, which is the seventh key of occlusion, which is a very, very important concept for not only for the undergraduates, but the postgraduates. So this is a really important concept. I am sure you have learned all those keys. So the question is seventh key of occlusion, which is the seventh key of normal occlusion, or you can say the seventh key of ideal occlusion. So the options that have been given to you are molar relation, palatal plane, crown angulation and inclination, and Bolton's ratio. Well, I feel this is the most easiest question because they could have asked you the fourth key or the third key, which might confuse you. But seventh key always you'll always remember because this is an exception. This was never there in the initial period. Uh, which was later added by Bolton and which came to be known as Bolton's ratio. We'll discuss it further and you will remember, I hope, from now on. So the concept behind this that initially Andrews were trying to find things which would lead to ideal occlusion because a lot of orthodontists would debate, okay, my occlusion is ideal, and the other one would say, no, 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 that's really bad. My occlusion is ideal. So he had to decide a few things upon which we can judge the occlusion of a person. If these things were present in the occlusion of the person, or I would say in the mouth of the patient, then his occlusion would be really good. And that is why the six keys of ideal occlusion. That's what Andrews gave. So the first thing which we study in orthodontics, which is the molar relationship, he called it interarch molar relationship or molar interarch relationship, which is class one. I hope you all know what class one means. Then the mesiodistal angulation, I mean the tip. Then labiolingual inclination. Remember, whenever we say labiolingual, we understand whenever we flare out the incisor, we call them proclined, not proangulated or something like that. We always say proclined. So labiolingual is always inclined, inclination, right? So labiolingual crown inclination, but before that comes mesiodistal crown angulation. Since inclination has already been included, you have only one option, angulation left. The fourth is absence of rotation. So you understand what he's talking about is there shouldn't be mesiodistal crown angulation, labiolingual crown inclination, or any rotation before you say that the occlusion is ideal, which of course makes sense. There should be tight proximal contacts. That means there should be no spacing. Well, of course. And there should be one additional that you have to remember is that there should be no curve of speed. The curve of speed should be flat. Well, as orthodontists, we always try to do that. I understand in generally humans, some amount of curve of speed is okay, but as an orthodontist, we always try to give them a flat curve of speed. I mean, that's what the concept was earlier. And finally, later, when orthodontists were seeing these things, despite having all the keys, they found that there was some problem, and yet the occlusion was not proper. I mean, they had all the six keys, and yet the occlusion was not proper. So the mystery then was resolved by Bolton's, who gave the ratio, who said, Dr. Wayne Bolton, who said that maybe the upper teeth are broader than the lower teeth, or the lower teeth are broader than the upper teeth, and that is why there is some problem in the occlusion. So seventh key, everyone would remember, I hope. So he also said that the anterior ratio of this mesiodistal width of upper and lower six is 77.2%, and overall ratio is 91.3%. And now this also makes sense because what it's trying to say is that lowers are 77.2% of upper mesiodistal width because upper central incisors are broader, lateral incisors are a little less broad, but they are broad, and the canine is also broad. Whereas in lower, the central incisor and the lateral incisor are like around 5 to 6 mm, right? They are almost equal. Lateral incisor being broader than the central incisor, of course, but they are almost equal and incomparable to the width of the upper incisor. I mean, the mesiodistal width of the upper incisor. Obviously, the upper would be greater in width, the upper six, as compared to the lower six. Hence, the lower are 77.2% of the upper. Whereas as we go behind the molar and the premolars, trying to counter this gap in the mesodistal bits, and of course, this ratio almost becomes 91.3. Okay, so that's how it is. So the fifth question is, which is again related to this classification which we just discussed, which is maxillary first molar cusp used in the angle classification is which one of the given options? So the first option is distobuccal cusp. The second is mesiobuccal cusp. Third is mesiolingual cusp and distolingual cusp. So I don't think this is a really difficult question, to be honest. And I'm sorry, there's no concept to understand, but I would say that every one of the students, I hope, remembers this thing wherein it is the mesiobuccal cusp. But I just want you to remember a few things around the option. So we understand whenever we are trying to define this class 1 malocclusion of by the angle said that the mesiobuccal cusp of the maxillary first permanent molar occludes with the buccal groove of the mandibular molar, right? So, but Andrews, when giving the first, he went a few points further, and I want you to remember is that the distal surface of the distal buccal cusp of the upper first molar, the distal surface of the distobuccal cusp of the upper first molar contacts with the mesial surface of the mesiobuccal cusp of the lower molar. Well, it makes sense, right? And finally, the canine and the premolars enjoy a cusp embrasure relationship. I mean, between the lower first molar and the lower second premolar, there should be the upper second premolar, and so on and so forth. And we all know it was further divided into types, which was called the Dewey's modification. And the type 1 is anterior crowding. Type 2 is spaced maxillary and anteriors or protrusion. And I have deliberately written this as type 2. When you can see, if you imagine these two sticks of two of being maxillary incisor, then the space between represents the space. So you would remember that type 2 is spacing, or spacing can only be possible when they are proclined. So proclination and spacing of maxillary incisor. Type 3 is anterior crossbite, so automatically type 4 becomes posterior crossbite. And type 5, as you can understand, again, I have deliberately, you can understand by type 5 because there is mesial migration of molar due to early loss of deciduous teeth, which is the fifth tooth, because the molar is the sixth. So type 5 is loss of fifth and mesial migration of sixth. So I want you to remember it this way. Okay, the problem with this classification we all understand is that only sagittal relationship of the molar was seen and the rest of the things were ignored. Initially, I mean, when Dewey's modification wasn't included, and the skeletal relationship was also ignored, incisors were also ignored, vertical relationship was also ignored. So all of the problems were there, and hence the modifications came afterward. So another question which is very important to understand is the sign of thumb sucking habit. Now, this question I feel is also very conceptual, and you don't need to mug up the signs of various habits that you encounter, and that is why we have discussed this question. So the first sign that they've given is deep bite. Concave profile is the second option. Third is convex profile, and the fourth is narrow mandibular arch. Remember, narrow mandibular arch. Okay. So of course, we understand the answer is convex profile, and why we'll discuss, and we'll also eliminate the rest of the options. Okay. So whenever, as you can see here in the picture in the right bottom corner, whenever the patient is sucking the thumb, he's applying two kinds of pressure. So the first pressure he's applying is towards the palate because he's pressing the thumb against the palate. Okay. The second pressure he's applying is on the tongue. He's not allowing the tongue to rest where it should, which is in the maxillary, around the maxillary teeth, maxillary arch. It is depressed downwards towards the mandibular arch. You can see, you can appreciate this. Okay. Plus, he is sucking, so the cheek musculature is tightly, snugly fit against the arches and are applying pressure and is applying pressure. Now, the tongue lies in the mandibular arch, so is able to encounter this. But maxillary arch has nothing but the thumb, which is not as broad as tongue and cannot apply that amount of lateral pressure. So what happens is the teeth experience only one pressure, which is from outside towards inside, and hence they go towards inside. Another pressure that he's applying in the anterior is on the upper incisors, he's applying the pressure outward, right? Because they are he's applying the pressure from the palatal side. So they are pushed outward. So these two things would lead on to first, of course, the first thing that we discussed, the maxillary crossbite, I mean posterior crossbite. The thumb lies between the upper and the lower teeth, and hence the open bite. The thumb applies pressure from the palatal side onto the anteriors, upper anteriors, I mean. So hence the flaring of the anteriors. So what would it lead on to? Of course, increased overjet, anterior open bite. And since the upper teeth, there's pressure on the maxilla outward, the mandible there, it is pressured in the backward direction because he has to put the thumb between the two, and hence a convex profile develops. And that was the option, given option. So you'll have to pick up on that. So it is normal up to 3 to 4 years. Then you have to intervene. There are a lot of things to intervene. And of course, I've already discussed that it can also cause posterior crossbite, deep palate arch, I mean the deep palate. And yeah, that's it. Okay. So this is the question which is being put up in another way. So whenever you are giving your exam, I want you to focus. Whenever you read the question, whenever you find this term only, not these kind of terms, you put special emphasis on it and read the question very, very carefully. Now, someone would see this, that which is not a change due to thumb sucking. Not is an important term. We know that it causes convex facial profile. Concave is mentioned. Concave is not a change due to thumb sucking. Convex profile would be the change, and hence this is the correct option. Backward, downward, and backward rotation of the mandible. Well, that's what causes the profile to be convex, hence this option is correct. It is a change that is seen due to thumb sucking. Increased overjet because there is flaring of the anterior upper anteriors, and retroclination, little bit retroclination of the lower anteriors. I mean, there could be, and hence there is increased overjet. And posterior crossbite, we have already explained. So these both are a change which is seen due to thumb sucking. So these options were incorrect. The correct was concave facial profile. It is not seen. It is not seen with thumb sucking. Okay. Okay. Another thing which is related to habit. Habit is a really important concept in orthodontics. So really focused upon that. So the question is, adenoids, the increase in the size of the adenoids would result in vertical descent of the maxilla, vertical descent of the mandible, vertical ascent of the mandible, vertical ascent of the maxilla. Before we try to counter this question, we should understand what adenoid is, where are they present, okay? So a lot of you, I've seen that they get confused between the adenoid that we are talking about here and the tonsil that we see in our mouth. I've seen people identify that as, okay, adenoids are inflamed, but not really. I mean, the tonsils are inflamed, yes, whenever we try to check, open your mouth and see the tonsils right behind the tongue, we are focusing on this, right? The tonsil. These, this is not, and we are, this is not something that we are talking about when we are discussing this thing. Uh, I mean, mouth breathing. So this question was the habit which was associated with this question was mouth breathing. So this question is linked to that. So you understand, try and understand that what you see here, just behind the tongue, I mean above the tongue and between the tongue and the palate, in the soft palate part, you would say you would see that is the, I mean, just closure of the upper airway, which is the end of the upper airway. So whenever these adenoids are inflamed, I mean adenoids, or there is a hypertrophy of the adenoid, which happens to up to a certain age and then it starts resolving. So at that point of time, airway is compromised. Now, what if they do not, I mean, resolve and they keep, they be there all swelled up and there's hypertrophy. So this airway is compromised again. Now the patient has to breathe. So upper airway is compromised. So anything coming through the nose and through the upper airway, the patient is not able to I mean, breathe comfortably through that. What he'll do is he'll open the mouth and hence develop mouth breathing habit. So when the mouth is opened, the oxygen also flows through this, and hence he can breathe comfortably now. And this mouth breathing habit due to adenoids would lead to what is called a characteristic feature, which is adenoid facie. So when if we imagine this as a clock, the circle as a clock, the mandible rotates downward and backward, which is a clockwise rotation of the mandible. If mandible rotates like this, the height of the face increases, right? So there is elongated face, and hence something called long face syndrome is also associated with the same habit. So mouth breathing would cause, would cause altered tongue posture, which is downward, the low mandibular position. When mandible is positioned lower, the anterior facial height increases, hence the long face. The lips keep, they are incompetent mostly, obviously, sometimes leading to short upper lip. The nostrils are not really developed because the patient has been breathing through mouth also, so they are pinched nostrils. The head is tilted backwards so as to make it easier for the patient to breathe, of course, and extended neck posture, and there's dull expression. So these things that I just mentioned are called adenoid facies. Long face syndrome is also associated because then the height of the face increases, and hence we can safely assume that the second option, which is vertical growth or vertical descent of the mandible, uh, it seems correct, right? Because it was not affecting the maxilla that much. Only mandible was being affected. The vertical ascent would further decrease the airway, right? Because the patient won't be able to breathe through the mandible, and hence the vertical descent of the mandible is the correct option. The ninth question we are going to discuss here is anterior crossbite. So What does the generalized anterior crossbite in the primary dentition suggest? Is it a normal relation? Is it developing deep bite? Is it developing class 2 or a developing class 3? Well, we understand some malocclusions are self-correcting anomalies in a primary dentition. So you need to know that, and you need to know which of them is not a part. So we understand that anterior crossbite is nowhere a part of self-correcting anomalies in the primary dentition. What we assume mostly is, since the mandible develops later, it grows later than the maxilla, because we understand the concept that whatever is closer to the brain or the cranium grows first. So maybe increased overjet can be a part wherein it would self-correct when the mandible grows. But a crossbite in which it is just the opposite of what seems plausible. I mean, increased overjet is plausible. Okay, I can understand. But crossbite, that means that the mandible is forward than the maxilla, which is absolutely, absolutely wrong. Okay, so we understand that this is not normal. So normal relation is cut out. It would be a developing deep bite. Well, we are talking about a sagittal problem. Where did this vertical thing come from? Okay, so you can safely cross this out. Now, developing class 2 and class 3. Now, this question becomes so easy for us because we understand, of course, you'll have to remember that the class 2 is when the mandible is back, and class 3 is when the mandible is in the front. So, this is a developing class 3 because mandible is in the front. I mean, anterior crossbite means when the mandibular teeth are in front of the maxillary teeth, like this in this image. So the mandibular teeth are forward, maxillary teeth are backward. So that's what it anterior crossbite look like, and this is the primary dentition. So that this is how exactly how it would grow. It might lead to later skeletal discrepancy because the maxilla won't be allowed to grow, and I mean, maxilla grows first, but it is locked behind the mandible, and mandible grows later. So mandible will not allow maxilla to grow when it's the age for the maxilla to grow. And later on, when the mandible's age come, it can freely go grow forward. So this case might lead on to skeletal class 3. Okay. So what do we do when we see this kind of a thing? Well, first to identify whether it is just dental, single tooth, or skeletal. Depending upon that, we take some actions. We can correct a developing crossbite. If it is developing, we can through tongue blade therapy, or through later few months later. I mean, when it has already developed, through Catlin's appliance, or if it is skeletal. I mean, these two were the options if it was dental in nature. If it is skeletal in nature, you will have to go for a face mask therapy. And if the age is such that the face mask therapy alone cannot pull the maxilla out, well, it is difficult when they have mentioned in the question primary dentition. But yes, if they mention the age, and if the age is more than, I mean, 13, 14 years, then simply face mask would not do you any good. You have to go for a rapid maxillary expansion so that it helps the maxilla to be free and move forward with the applying force. Okay. So the last question we are here to discuss is crossbite with shift on closure, right? So the question is, a child, again a case base, a child with unilateral crossbite and deviation on closure is suffering from. So the options that you have is unilateral constriction of maxilla, bilateral constriction of maxilla, bilateral constriction with deviation, unilateral constriction with deviation. Okay. So this is something which is mentioned in Profit, and it is covered. I would say this question is a little towards the PG side. As postgraduates, you will understand that whenever there is crossbite and they are saying unilateral crossbite, never assume that since it is unilateral crossbite, so the culprit is also unilateral. It is never the case. Mostly it is seen, mostly it is written that mostly it is seen that the maxilla is constricted bilaterally, but body has this really awesome mechanism. Always remember from general path, I hope you remember that whenever there is any problem with the body tries to normalize it as much as it can. Okay. So whenever there is reduced red blood cells, it would increase the precursor in the bone marrow so that more red blood cells are produced, right? Same concept. Whenever there is constriction of the maxilla bilateral, body thinks and says, okay, the patient cannot chew from both the sides. I mean, So what we can do is normalize the occlusion. I mean, try to normalize the occlusion on at least one side and let the deviation be more on the other side, because anyway the patient is not able to chew. And exactly that's what body does. It normalizes the occlusion on one side and shifts the mandible towards the other. So I'll look at this image. The On the right side, the occlusion seems to be normal, but here it is shifted. But can you compare the size of maxilla and mandible? Don't you see the difference in the width? Well, of course, the maxilla is constructed and the body has tried to normalize. It has shifted the mandible towards the left side of the patient so that the right side of the patient becomes normal, and the rest on the left side, the deviation is more. Well, it doesn't matter because the patient is going to chew from the right side anyway, but at least the patient will be able to chew. So that is the concept. That's why the body does it. So always remember that the right answer is bilateral constriction with deviation, because there is deviation. The question itself is mentioning it. So there's no doubt about that. So it is bilateral constriction with deviation. Okay. So you should also understand when there is constriction of maxilla. I think we'll clear out the concept here only. There are a lot of options that you have, and it totally depends upon the age of the patient and various other factors, of course. So first of all, if we consider if we keep the age in mind, so you can give a few removable appliance. You can always opt for a jack screw along with a expanding plate. Uh, the second thing that you can give is quad helix. So quad means four, helix means circles. So you can see four circles. So this is quad helix. Then W arch. It looks look at this image. It looks like a W. Okay. So W arch. If this has to be given in very early age. So when there is a primary dentition, ages 6 to 9, then you can always go for this early mixed or primary dentition. In the late mixed, then you will have to go for preferably go for rapid palatal expanders, because this might these two things also might help, but they will help you more in case of dental problem, and they won't help you much in case of skeletal problem. So whenever the maxilla is constricted, so we understand that this is a skeletal problem. They are not saying that the maxillary dentation is such that they are saying maxilla is constricted. They are mentioning skeletal, so we have to keep in mind about that. So we'll have to go for a rapid maxillary expansion. Well, if it's late adolescent period, so rapid maxillary expansion expander won't help you anyway. You'll have to go for MARPE, preferably, or SARPE. So preferably MARPE. MARPE is mini implant assisted rapid palatal expansion. So you can see these mini implants, the mini screws here, 4 mini screws that will help you with skeletal expansion, and see the midline diastema which has developed. So they have expanded it quite well. So midline diastema, the developing midline diastema after expansion is an indication that the expansion has taken place. And finally, when the patient is 18 years and above, you do not have any other option but to go for SARPE, surgically assisted rapid palatal expander. Of course, age is not the golden diagnostic thing. The best thing is to go for CBCT and judge the maxillary suture. If depending upon the level of fusion, you'll have to decide which appliance to get. So yeah, this was all for the questions and the PPT that was discussed. Thank you so much for your time.